My name is Thato Mosidi, and before I start my presentation, I just need to excuse myself. I'm having an upper respiratory tract infection, but I'll try to project as best as possible. So today I'll be speaking to you about the catastrophic costs faced by TB patients and their families. But before I do so, I'll introduce who I am and where I'm from. I'm part of an organization called TB Proof, which is a small civil society organization that was founded in 2012 in South Africa by a group of medical students and nurses and health students. And we were all brought together because of a common event that happened to us. And like myself, an ex-DR TB survivor, all my colleagues were also infected with TB in their workplaces. And since surviving our own experiences and having undergone this harrowing journey of taking treatment for TB, we have pledged to be advocates for patients around the world who have TB. And most of our advocacy activities revolve around advocating for improved and easier access to care for patients with TB and the use of non-toxic quality TB drugs and freedom from TB stigma and discrimination. But today, the particular reason I'll be speaking to you today, on behalf of all people with TB and their families, is to raise awareness and remind everyone about the devastating economic effects people with TB and their families have to encounter. So most of you are familiar with the NTB strategy and support its vision of a world free of tuberculosis. And in order to reach this goal, there have been 3 vital post-2015 indicators which have been set, which will track our efforts in this regard. And these indicators are namely reducing the number of TB deaths by 90 and 95%, reducing the incidence of TB by 80 and 90%, and having 0% of TB-affected families facing catastrophic costs due to TB by the year 2030 and 2035, respectively. And this third indicator is set to be achieved by the year 2020, which means we have less than 2 years to go. But before we discuss some of the interventions that have been implemented to mitigate the additional suffering faced by TB-affected families, let's take a moment to understand exactly what catastrophic effects these patients are experiencing. So it's near impossible to speak about the determinants of health and TB without referring to the synergistic relationship between TB and poverty. And an understanding of this complex nature of this relationship is powerful means to working towards stopping the suffering of millions of people around the world and for eliminating the TB epidemic. The economic and the human impact on TB is many times greater on poor households and poorer nations than in the developed world. And the high incidence levels of TB found in many low and middle income countries means a sick labor force, extra strain on limited health services, and shackled economic growth. And in fact, studies have suggested that the average patient loses 3 to 4 months of work as a result of tuberculosis, and even more months of work can be lost in instances of drug-resistant TB. Thus, TB is able to weaken country by lowering their gross domestic product and also pushing families further into poverty due to loss of earnings. And conversely, poverty also fuels TB. And it does go through various mechanisms, such as having poor access to healthcare, which will result in delayed health-seeking behaviors and consequently an increased spread of tuberculosis and increased morbidity in the community. And poor living working conditions tend to translate to overcrowded and poorly ventilated home and work environments, which will also contribute to the spread of tuberculosis. Food security or inadequate nutrition is also another issue, as this will result in weakened immune systems, which puts people at risk of being infected with tuberculosis. And once again, the person who has TB, we can see how the cycle continues. So what do we mean by catastrophic costs? This term usually refers to the hidden costs that patients with TB and their families incur even when treatment is free. And it's usually calculated as the number of people treated for TB and their households who incur catastrophic costs, which are both direct and indirect combined, divided by the total number of people treated for TB. Catastrophic costs have been provisionally defined as total costs that exceed about 20% of the annual household income. And in instances of drug-resistant TB, this figure rises to about 67% of this annual income. And some of examples of catastrophic costs include the travel costs that patients have to incur. And this is particularly a problem when you have patients coming from rural areas and very remote locations. Another issue that, of catastrophic costs that patients may incur is, for example, going to consult with traditional leaders. So, for example, in South Africa and probably many other African countries, patients tend to go to traditional leaders to seek help before they come to a Western health facility to seek for, care for TB. There are also private provider fees that one has to consider. And usually when patients go see these private providers, they have to pay fees for tests and their consultations. A particular problem that patients face is the multiple visitations to health facilities. And this happens during the pre-diagnosis, during the treatment stage, and the follow-up visits that patients have to go to, and also with picking up their medication. And again, this is related with the travel costs that patients have to incur. Other catastrophic costs that patients incur is buying other medications. So even when a patient is taking their TB treatment, which they might have received for free, they still tend to buy other drugs to help some of the problems and the side effects that they're undergoing. When patients have also been hospitalized, mostly due to complications, and this tends to be quite sudden and unexpected, there may be additional costs that have been incurred. Other issues that patients have is the food costs. So patients will incur catastrophic costs when alternative foods to what the family usually buys is bought, and also the supplementation that they may need to continue with their ongoing, with taking their TB medication. They may also incur costs due to the caregiver and a childcare. So costs may be incurred to those people who are accompanying patients with TB to their visits, for retrieving medications on their behalf, or just in general the cost of caregiving activities. And these direct costs encompass additional travel expenses, food, or other costs such as paying for overnight stays, particularly when a patient is when making a long journey and you're taking a patient from a remote place. The caregiver themselves can also experience loss of income if they are working, and again, there's also the loss of time. Childcare also seems to be an additional cost that patients undergo, and it costs quite a lot for them to pay for someone to take care of their children when they are not able to do so. But it seems like the main issue that most patients talk about is the loss of the income, which can be pinned directly to the number of months spent away from work. And I mentioned that it could be 3 to 4 months in some cases, in TB cases, but definitely more when you have instances of drug-resistant TB. And possibly the one cost that we can't quantify is the loss of time. The illness itself takes time away from patients, but importantly, it also takes time away from the loved ones, from patients' loved ones. Okay. So what can be done? So 2 useful approaches have been proven particularly useful, which is the implementation of universal health coverage and social support. So specifically with UHC, it means that everyone will have access to the services and address the most important causes of disease and death, and it will ensure that the quality of those services is good enough to improve the health of the people who receive them. In order to achieve universal health coverage, high-level political will and bold policy will be required. And certainly regarding the political will, there have been strides in this regard. And platforms such as the first ever UN high-level meeting on TB that will be held in September provide excellent opportunities for nations to engage with their leaders in matters related with TB. And all of community, so civil society, implementers, researchers, private providers, to mention a few, must take advantage of this opportunity to push the agenda of universal health coverage to be implemented in their societies. So as a patient advocate, I've had the privilege of meeting and hearing many stories of survival from other TB patients. And I'd like to share one such story with you that details the challenges that this lady and her family had to encounter while she and her 2 children were undergoing care. Nosipho, which is not her real name, is a 41-year-old woman living in rural province of Eastern Cape in South Africa. She lives with her elderly grandmother, her younger sister, and 5 young children in their small home. And her story is as follows. I didn't even know what TB is. All I noticed was that I was losing a lot of weight and I could no longer do chores around the house. I even struggled with putting on my clothes and making food to eat because I felt so weak. I noticed that 2 of my children were also looking sickly and were losing weight rapidly too. I didn't know how I could reach the hospital to see a doctor. My village is almost 200 kilometers away from the nearest hospital, and the mobile clinic only comes to my area once a week. My sister decided to ask a neighbor of ours, whose brother has a van, to transport us to the clinic in town. We had to pay him some money for petrol, and unfortunately it came out of the family's food budget. My husband lives and works as a miner in a different province and sends me money monthly, but it is not enough to cover all our needs. At the clinic, they told me I had TB. This is after visiting the clinic 4 times. I was concerned about all the trips I would have to make to the clinic to get my treatment. At that point, I didn't know how we would cope because the girls had also been diagnosed with TB. I decided then that it would be best if we didn't put any pressure on the family and not attend our appointments rather than letting everyone starve to death. We missed our next appointment, and the clinic sent a community health worker to our village to come find us. I broke down in tears when I told her how we had no food to eat and no money to get to the clinic because my husband had stopped sending us money. All we relied on was the food in our small vegetable garden, which was not yielding any produce because of the drought. The lady told us we could get assistance from the government for some of our problems. The children were registered, and after a few months, we started receiving money from the child support grants. The mobile clinic would deliver our medication to us every month, which was very helpful. The community worker also told us that the NGO she works for had a soup kitchen and that we were welcome to eat there. While attending the NGO, I also learned how to make clay pottery and beadwork, which we could sell to tourists and help generate some income for the family. My daughters and I have now finished our TB treatment and we are healthy again. I don't know how we would have survived if the community health worker had not helped us access better care and if not for the NGO teaching us how to make an extra income for ourselves. And it's stories like this that show how little support through social protection and providing better access to care can really go a long way. So some notes on social protection. There's been many different interventions that have been implemented in communities to assist people like Nosipho and her families. And some of these examples are noted here. So we have interventions like, cash transfers provided via national TB programs or the Global Fund, food provided through nutrition programs, transport assistance or transport vouchers provided by NPOs, TB patient income generation projects, social welfare grants, such as the child grant I mentioned, and also temporary disability grants for patients with TB, and person-specific support for social need. These have all shown to have very positive outcomes when it comes to managing and supporting patients and their families. And to show the effectiveness of improving access to care and implementing social support, there have been studies such as this one on the slide that was conducted by Virgo et al. In South Africa that shows how expanded access to care has the potential to decrease household tuberculation-related costs by almost 5 to 20%. And more importantly, that these benefits would be greatest on the poorest households. So countries around the world need to start acknowledging such interventions and their merits and implementing measures to assist those who cannot help themselves. So in conclusion, we have to realize that it will take a commitment from all stakeholders in order to achieve our 0% target of families who have patients with TB facing catastrophic costs. And I urge everyone in this room to consider what role that they can play in contributing towards the alleviation of suffering by people with TB and their families. Thank you for listening.